Hi, this is Diva's Korea. I'm just going to talk about the thromboprophylaxis with the low molecular weight heparin versus unfractioned heparin in intensive care patients. A systematic review with meta-analysis and trial second show. I'm going to talk about most of the importance of thromboprophylaxis with low molecular weight heparin versus unfractioned heparin in ICU patients. Most of the ICU patients or hospitalized patients in the ICU might suffer from venous thromboembolism, either deep vein thrombosis or pulmonary embolism. VT may be present on admission to ICU or can be developed in an ICU stay. Pulmonary embolism in particular is considered to be an important preventable complication in ICU patients. However, the clinical importance of asymptomatic and distal VTE is uncertain, as there is no clear evidence to support treatment of this condition. ICU patients are supported by heparin thromboprophylaxis in different groups such as low molecular weight heparin or unfractioned heparin. Such treatment could potentially benefit the patient in lowering the risk of thrombus but can also cause serious side effects such as increased bleeding. This study highlighted that anticoagulant thromboprophylaxis is a trade-off between thrombotic and bleeding risk, which emphasized the importance of searching for the optimal preventive drugs. Moving on to the next slide. Search strategy used to retrieve the information. Evidence were gathered from punishments up to and including 3rd December 2014 from Ovid Medline, PubMed, Embase, Cochrane Library, UpToDate and Guidelines International Network. Ongoing studies were identified from Searching for Spiro, the international database of prospectively registered systemic reviews in health and social care, and the Meta-Register of Controlled Trials. Medical subject headings and terms in the title or abstract were searched alone or in combination, including pulmonary embolism, thrombosis, intensive care, anticoagulants, and thrombosis prophylaxis were searched from Ovid Medline. The populations were limited to adult human above 18 years and language to English and Scandinavian. The most of the adults selected for 36 years to 56 years in the ICU settings. Just going on to the next slide, which is evidence for the intervention. That data extraction and quality assessment. Two investigators extracted the data, ICU population, thromboprophylaxis, and significant clinical outcome in the included trials from adult medical, surgical, traumatized, and mixed ICU patients. Any comparison of thromboprophylaxis with low molecular weight heparin versus unfractioned heparin was further evaluated. Also, when used this combination with other medical or mechanical thromboprophylaxis, primary outcome was occurrence of DVT, pulmonary embolism, and severe bleeding, whereas mortality and length of hospital stay and heparin-induced thrombocytopenia were secondary outcome. A clinical benefit endpoint was considered including at least one of the following events such as DVT, pulmonary embolism, major bleeding, or mortality. The investigators considered the quality of the trials according to the Cochrane collaboration tool for assessing risk of bias. Analysis state that all dominants should have a low risk of bias in order to be classified as having an overall low risk of bias. On this article, there are 4 authors assessed and separately assessed the quality of the trials. Any discrepancy was resolved by discussion and consensus. Next, moving on to the level of evidence was based on the different analyses. There are 2 groups. I'm going to use it for analyzing this evidence, which is subgroup analysis, and the second one trial sequential analysis, and third one sensitivity analysis. Subgroup analysis, this was stratified by population, intervention, co-intervention, and study quality. Heterogeneity between groups appeared, but the statistical test of heterogeneity between trials was power deficient. Subgroup analysis revealed a variation in pooled effect for some outcomes. The second trial sequential analysis was performed post-hoc to assess the risk of random errors false positive results and to help clarify the need for additional trials. Trial sequential analysis, including all trials, revealed that our meta-analysis had enough power to detect 20% of reduced relative risk reduction for DVT and clinical benefit. The third analysis is sensitivity analysis. Post-hoc sensitivity analyses were conducted to test if the result of the analysis was strong to the decision made in the process of obtaining them. Sensitivity analysis reveals stability of the pooled estimates irrespective of whether random or fixed effect. Statistical method was applied when considering the two trials the overall risk of bias. It shows low risk of bias. The result of the analysis showed that low molecular weight heparin combined with unfractioned heparin reduced the risk of DVT and resulted in clinical benefit. There was no statistically significant difference in the risk of pulmonary embolism, major bleeding, or mortality. Moving on to the next, the outcome of this study. The importance for practice of this meta-analysis is that a considerable number of patients could certainly be saved each year from developing clinically important events if treated with low molecular weight heparin instead of unfractioned heparin. Therefore, I believe that low molecular weight heparin should be preferred above unfractioned heparin as thromboprophylaxis in ICU patients, even taking into account the spare number of high quality of random controlled trials. And other thing is that the cost, the length of patient staying in the ICU and the cost is most important on the ICU settings. In the conclusion, this systemic meta-analysis and proved a net clinical benefit of low molecular weight heparin compared with unfractioned heparin as thromboprophylaxis in ICU patients. And I'm some art reference related to this article. Thanks for listening to this presentation. Okay.